All right, so I showed you that this is all wonderful, right? Erlotinib is a great drug. Afatinib is a great drug in this setting. These really shrink EGFR mutant lung cancers. But when you look at these progression-free survival curves, which again, is wonderful, it's way better than chemotherapy. But you look out there at 15 months, 18 months, and you see that 75, 80, 90% of patients have already begun to progress at that point. What do you do? What do you do for patients who have acquired resistance to erlotinib and gefitinib? So this is, again, afatinib, even the newer drug. When you look at 21 months, 80% of people have had progression of disease. So first question we have to ask is, how does acquired resistance occur? What is the mechanism behind it? What's the cellular basis for that? And the only way we can really learn what's happening in people is by biopsy. These are images of CT-guided needle biopsies that we've done, and when we were trying to figure this out back in 2004, we did this as part of a prospective clinical trial, biopsying patients and identifying secondary mutations. Now I think it's generally considered standard of care, and most of us do this routinely to understand what's going on with our patients, because this is the picture we're starting to see. These are the observed mechanisms of acquired resistance. And I'm not going to spend a whole lot of time talking about most of these, but I'll again highlight the small cell transformation. It's very uncommon, 3-4%, but it's interesting to know about, and I think it's one of the key reasons, the key pieces of rationale for why we do biopsies in the acquired resistance setting. We need to identify that and treat that appropriately. Again, T790M is by far the most common. You see this 60% here, but it's actually 60% plus a couple others, because if you look at the top right, HER2 amplification plus T790M occurs in another 4%. MET amplification on the bottom left plus T790M occurs in 3%. And small cell transformation plus T790M occurs in another 2%. So that actually works out to 69%. Two-thirds of patients, when they have acquired resistance, have EGFR T790M. So by far the most common mechanism of acquired resistance. So how do we manage this? In clinic, what do we do? I think one of the things that probably you have seen and we saw back when we started thinking about what we do in this situation is that when we saw patients who were progressing, and we did what we're supposed to do. We stopped EGFR TKI back long ago. Patients seem to do badly. Certainly we see that with chemotherapy. When they're progressing and we stop the chemotherapy, they continue to do badly. But our sense was that this might actually be something more going on. And this is a set of PET scans from a prospective trial we did back in the early 2000s. And this is, you see on the far left, is a patient who we had defined as having resistance. They had growing lung nodules, increasing burden of disease on CT scans, and by the rules of the day, we would stop EGFR TKI. So we stopped. And then 3 weeks later, as part of this trial, we did another PET scan. No intervening therapy here, so chemo hadn't been started. We were just trying to find out what happens to these folks. And you see that there's a significant increase in the burden of disease, more cancer in lots of places. And then, importantly, to try to find out whether this is just a mere effect of continued progression or this is something that was being suppressed by the EGFR TKI, we restarted the EGFR TKI, and we saw significant control of the disease. Interestingly, as we did this trial, we put 13 patients on. 3 patients actually had to come off the study because they had clinical worsening of their disease, where one person had cord compression, one person had progression in brain metastases that required us to stop what we were doing, give some steroids, give them whole brain radiation therapy. So it was kind of a big deal. And that actually became our standard, was to continue patients on EGFR TKI, at least until the next line of therapy started. But we also were doing lots of clinical trials of newer agents, trying to understand things. And most of these clinical trials, as you guys all know, require you to stop prior medicine before patients go on the study. And so more recently, we looked back to see what happened to our patients who we stopped drug on. Most clinical trials required a washout period of 7 to 14 days. And we looked at the patients who signed consent to go on to these next generation trials and stop drug. We had 61 patients, and we decided to come up with a very tight definition of what you'd call a flare of disease. And our definition of flare was they died or they ended up in the hospital after stopping drug. And we found that 14, and again, these are patients who signed for clinical trials, so this is not somebody you were thinking about sending to hospice. This is somebody who was going to go on a clinical trial. And 14 out of the 61 patients that signed on to clinical trials where you had to come off drug had hospitalization or death in a median of 7 days. And sometimes we like to say we can pick out which patients we should or shouldn't stop. We weren't able to figure that out in this situation. We looked back at lots of different clinical predictors to try to sort out which ones would predict who would have flare. We couldn't do it. So my conclusion from these sets of data is that if you plan to discontinue erlotinib, really do so only after or just before initiating our alternative therapy. So don't stop and then get your insurance clearance for pemetrexed and give the B12. Start all that up before you stop the erlotinib. So this idea of continuation of erlotinib actually made it into the NCCN guidelines, and I think this projects okay here. It's kind of a busy slide, and the first grouping there is really about initiating therapy, and so I guess we can walk through it. Sensitizing EGFR mutation on the far left, and if an EGFR mutation is discovered prior to first-line therapy, which most of us see, but sometimes we don't, but if you're figuring out your first-line therapy, then give either erlotinib or afatinib. And then after patients have developed progression, if you have asymptomatic disease, as many of us see this problem in one of the cases described, you can just continue erlotinib or afatinib. That's a very reasonable approach. And then for symptomatic progression, then we're going to kind of talk about the various ways going forward. But the notion of continuing a drug on which you've progressed is a bit of a foreign concept to oncologists, but I think it's reasonable in this setting, and we need to think about it. But the data I've shown you is not impressive, right? It's not like randomized clinical trials. So what other data do we have looking at this? So here's a bit of data that is a counterpoint. I have two counterpoints to my argument that you should continue erlotinib. And the first one is a retrospective study. This is a small retrospective analysis. Don't have the numbers on here. It's fewer than 50 patients, though, in this retrospective analysis. And this looked at patients who began platinum doublets or single-agent chemotherapy after development of acquired resistance. And on the left, you see the group of patients who began a platinum doublet, those who began the platinum doublet with erlotinib or platinum doublet alone, and you see no difference in progression-free survival. And on the right, those who started single-agent chemotherapy with or without erlotinib, no significant difference in progression-free survival. They did see an improved response rate when there was a combination. I'm not sure what that means in the context of an absence of increased progression-free survival. Importantly, there was no difference in overall survival. The small numbers lead us to limited power to say that this is, the conclusion is that there's no difference, but when you have a small series and you don't observe a difference, it's hard to tell whether that's just because the difference is small. But nonetheless, this argues against continued erlotinib after initiating chemotherapy, though I would still say up until you start that chemotherapy, continued erlotinib makes sense. And when I say erlotinib, you can always substitute afatinib or erlotinib or afatinib if you've chosen to use afatinib as your first-line therapy. So this was my big hope. Actually, I'm going to tell you guys something that I don't tell too many people. So this trial is a trial that I proposed to the sponsor 7 years ago, and they said, "Oh, I'm sorry, somebody else has already proposed this." And so this is Dr. Hamos's trial. He was the one who got this trial instead of me. And he led this trial first when he was in Cleveland at University Hospitals Cleveland, and he completed it now when he's at Columbia here. And this is a trial designed to answer the question. It's a prospective trial evaluating the value of continued erlotinib. Took patients with the standard stage 3B or 4 disease. This is, again, a trial designed a long time ago, so it didn't require EGFR mutant cancer, but it kind of selected for that, for having patients with more than 12 weeks of stable disease on erlotinib. And performance status that was fair, 0 to 2, and no more than 1 prior cytotoxic regimen. Patients were randomized to the idea was that this was also back when we didn't do a lot of first-line EGFR TKI, so these were all single-agent chemotherapies, and patients were randomized to either chemotherapy in the top or chemotherapy plus continued erlotinib. You see the planned numbers of 39 in each arm were designed to evaluate hoping for a big benefit, I think looking for 100% benefit, or I'm sorry, a doubling of progression-free survival. So aggressive statistics, and aggressive statistics are okay, except when you can't actually accrue the trial either. So this trial had to stop because of slow enrollment, and only 24 and 22 patients were randomized into each arm, and so as a consequence, this trial was a little harder to interpret. So this is the data. I was trying to get the actual slides from Balash. I couldn't get them, and if you guys, I don't know if you guys have checked out the ASCO virtual meeting. The pictures of the posters are kind of funny. They're hard to work with, so we don't have those slides. But nonetheless, this is the comparison. Again, similar to what we saw in the retrospective analysis I showed you a minute ago, there was an increased response rate when you added chemotherapy to erlotinib, but no difference in median progression-free survival. Actually, I rounded these numbers. For chemo, it was 5.6 months, and for chemo plus erlotinib was 4.5 months. Median overall survival was the same, and all the p-values are non-significant. So this tells us that, again, in an underpowered setting, there's not a lot of difference for continuing erlotinib versus chemotherapy. So that questions the role of it, but I think my experience suggests that it's valuable to continue erlotinib, and as a consequence, I generally do, as these guidelines suggest. But what about the patient who has a single site of progression, something that's a little bit more manageable? Can local therapy play a role? I know that that's not part of, we'd certainly radiate painful bony metastases. Most of us, I think, radiate brain metastases that come up on therapy. But is there a more broad role for use of local therapy to manage acquired resistance? And I think many of us do that sort of thing as a matter of course, and we decided to look back at what we've done over the last 5 or 6 years, and we looked at all patients with EGFR mutant cancers, and we looked at any of those patients who had local therapies. Now, this isn't CNS-directed therapy, because I think of that as standard of care, doing brain metastasis, giving SRS to a brain met. That's kind of standard of care. But what about things like radiofrequency ablation for a lung lesion, lobectomy for progressing lung lesions, wedge resections, things like that? And this is the variety of local therapies we've done for patients over the years. And what you see is that there's a lot of different things you can try, and certainly things that we've tried. When we looked to see what happened to these folks, we found that if we did some sort of local therapy, the median time to progression after that local therapy was another 10 months. Now, all these patients continued on erlotinib after that local therapy, so that's probably why. But I think even more when I think about what we do in clinic, the median time from a local therapy until we had to change systemic therapy, they may have progressed after a median of 10 months, but at the time until I felt like I needed to do something more was 22 months. And the median overall survival from local therapy was 41 months. So it suggests that this actually is a reasonable approach. This is very select data, very selected patients. This is the ones we did this on. And how you, as a doctor, think about which patient you might do this on is not captured here. And I have to say, I don't know if I could write it down on a piece of paper, but I think that generally those patients who benefited the most are probably the people who benefited in this setting, and also the people who truly had local progression. It wasn't somebody who had a little bit of growth in the lung and a little bit of growth in the liver, and then we decided to do an RFA. It was really somebody who had rock solid control in the lung and then a liver lesion growing. That's probably the person you want to do an RFA to the liver, or somebody who has near CR after initial treatment and then one lung nodule starts to grow. That's the kind of person who we would do this on. So just for conclusions on local therapy, in selected patients, local therapy can lead to extended progression-free intervals. Outcomes are best in the setting of true oligometastatic disease, and continuation of EGFR TKI was standard in this setting, and it may be a very important thing. So what about new therapies? I told you about T790M as really being one of the key things, and so that a mutation in T790M really means that the tumor continues to depend on EGFR as a mechanism of its growth. And so targeting EGFR is a wise thing. So one way to do that is, again, with afatinib. Afatinib is this newer molecule. It's an irreversible EGFR inhibitor that has activity against T790M. And I told you about the Lux-Lung-1. This is a trial where patients were randomized to either afatinib or placebo, and we saw no difference in overall survival for patients who got afatinib as compared to placebo, but in progression-free survival, there was significant improvement for afatinib, and in patients who got no subsequent therapy, afatinib led to improved overall survival. So if you're going to choose between nothing and something, afatinib is certainly reasonable as compared to placebo. It's recommended as compared to placebo. But again, the overall survival benefit in the overall population makes us question whether that's the right thing to do. And one other thing, when we're thinking EGFR dependence, can we just add another EGFR inhibitor to that? And that made us think about trying to add cetuximab to erlotinib, say. And this is a trial that's oft forgotten that I did 3-4 years ago, where we took patients who had progressed on single-agent erlotinib and then added cetuximab to it. This is the schema for the dose escalation, and this is the waterfall plot for patients who got erlotinib plus cetuximab. And what you see here is that only one patient had more than 30% shrinkage that might have met criteria for PR, but actually that one patient who might have met criteria for PR had progression elsewhere, and so that isn't a PR. And there were no PRs in the patients that we treated with erlotinib and cetuximab, and so this notion of combined EGFR blockade didn't seem to really hold water. But that wasn't the only way you could do combined EGFR blockade, and another way is to use the newer drug, afatinib, and combine that with cetuximab. These are CT scans or MRIs, actually, of mice. In case you can't tell, those are a little different than the ones we see every day. But what they show is that if you tried afatinib plus cetuximab in EGFR T790M L858R mice, there's actual shrinkage with afatinib and cetuximab that you don't see with either as a single agent alone. Again, mice are cute, but what you want is to see clinical data. And this is a trial. Dr. Janjigian spoke to you guys yesterday about esophageal cancer. When she was a fellow, she worked with us in the lung cancer group, and she helped push this trial forward, combining cetuximab and afatinib. This is a phase 1b trial where we ramped up the dose of cetuximab and then treated a whole bunch of patients with the combination of cetuximab and afatinib. And this is the waterfall plot for this, much better than that waterfall plot I showed you for erlotinib and cetuximab. When you actually give afatinib and cetuximab, you see significant responses, and it's irrespective of T790M status, and the overall median progression-free survival was 5 months, suggesting that patients are deriving long-term benefit from this. So I think that there are a lot of challenges about moving that combination forward. It's likely going to move forward in evaluation in a randomized setting through the cooperative groups. There's going to be a first-line trial comparing initial therapy with afatinib to afatinib plus cetuximab for patients with newly diagnosed EGFR mutant lung cancer. And there's still discussions about a trial in this setting that we care about today, which is the acquired resistance setting. We're going to learn more about how that works. So to summarize for cetuximab and afatinib, it's a proven high response rate in EGFR mutant non-small cell lung cancer with acquired resistance. The combination is not FDA approved in this setting, and it's not even recommended in the guidelines yet. So unfortunately, it's not really available for use unless you guys can talk the insurance companies into paying for this cetuximab. And randomized trials to evaluate this combination have not yet begun, but are in planning. So what's next? And I hinted this earlier, and I just wanted to remind you that I think this is an area of excitement. Third-generation EGFR tyrosine kinase inhibitors that are mutation-specific are likely to be where we are going forward. So just to summarize, patients who have acquired resistance, I think that erlotinib or afatinib should be continued at least until the initiation of next line of therapy, and I generally in practice continue it with chemotherapy. Local therapy should be considered. Afatinib and cetuximab combination has significant activity and will be evaluated in randomized trials. And finally, mutation-specific third-generation EGFR TKIs appear promising. So I'll close there and leave it for the next discussant to do the wild type.